as Don and Carly pointed out, scaphoids are kind of hard because they don't hurt enough, so they're easy to be missed. You know, usually if you break your bone, you think you ought to go to the ER, and scaphoids don't fit into that area. They don't hurt all the time, so people have this pain that comes and goes, so they think, oh, that's the wrist that I sprained in football, and now I sprained it again in basketball, and so it's not a constant sort of pain. Usually when you break a bone, even if you don't go see anybody, your body heals it, and the scaphoid doesn't behave like other bones, so it doesn't heal, which is problematic. And then even most bones that don't heal properly still aren't as much trouble, but 100% of the time if your scaphoid doesn't heal, you're going to get arthritis at a young age. And so they, you know, if it's picked up, it comes to need an operation. So, you know, a paper that was done out of about 400 scaphoid fractures in our place, 25% were missed initially. It's a common dilemma for all of us. So that's one of those, keep your index of suspicion high. And the sensitivity specificity paper that Don looked at, but, and as somebody pointed out when they're asking, everybody hurts when you push in your snuff box. So it's very sensitive for a scaphoid fracture, but it's very non-specific because a lot of people hurt there. And so you have to do this combination of exams that you'll go through a little bit to try and get that so you know. One of the big differences, and I think this is the hardest thing to try and advise a group who hasn't spent, you know, literally a long time trying to look at x-rays and trying to look at kids, et cetera, is that we really use the x-ray as a branching point for us. Not only in terms of ordering it, but our own interpretation of that. So when the radiologist says there's a fracture, when we look at it, we then have the ability to sort out, is that a fracture you have to worry about or not worry about? That's going to be a really hard thing in this, is how do you know which ones count and don't count? And as Carly pointed out, sometimes these little subtle things turn out to be a big deal. So it's just something to keep in mind as we try and work through this. What we're going to focus on today is really almost three tiers a little bit. What can you do in the office? What can you stabilize in the office and then send along? And what should you send now either to us or to the ED a little bit? And then we'll tease this out as we go. Everybody hurts, so pain is present but not necessarily a discriminator. Where they hurt matters a lot, as we'll talk about going through it. Swelling makes a big difference, and where it is helps you sort out, is it you know, a typical thing like a ganglion? Is this trauma? Is this you know, spider bite in the middle of the summer that's causing this inflammatory reaction? Is this an inflammatory arthritis? What is that swelling? How much is their motion limited, and particularly persistent limitation of motion? So you fall on the soccer field, it's going to hurt. It's probably not going to move more normally through dinner tonight, but what's it like tomorrow, the next day, the day after? And really what matters a lot is if they start to lose strength, that means that they're developing atrophy. So when you look at the other side, that gives you a lot. So one of the first things I do in inspection is literally look, particularly kids with chronic complaints, how much muscle mass have they lost? Because that tells me how much their pain is really affecting their function and how serious am I to take that complaint about pain. This isn't this kid telling me what they think, but some things are pretty obvious on exam. So this is a glass laceration with cut tendons, right? And that finger can't bend on its own. If you remember nothing else today, remember how to do a tenodesis exam, because it's a really pain-free way of assessing lots of things about fingers. And we'll delve into that. But you're going to compare to the other side. So with kids, particularly scared kids, I always start on the other side and examine that first. And I always educate them how to do it with me, so that when we get to the hurt part, that's the last thing we do. Because as you guys know, game's over once you hurt them. Don went into great detail on this, and we'll work on it. But what do you see in the office? You're going to see blunt trauma without obvious deformity, so look for deformity. You're going to look at closed injuries, so you're not going to do lacerations or crushed injuries. And you're going to see a lot of overuse. The same way with the knee, you're going to see overuse. So the location matters. So you got to evaluate and then decide after your evaluation, are you going to treat it? You got to refer to radiology, and when do you do that? And as Carly pointed out, we have a very low threshold for getting x-rays. And then if you're going to send it to orthopedics, when do you do it? And one of the things we'll have to figure out is this advice back and forth, how to help. And then the ED, it's always been a goal not to jam up the ED with unnecessary visits. They're expensive, they're time consuming if we can take care of that. So the tiered approach for office really has to do with comfort level and competency, so hopefully we'll help with both of those. Same with office care. And then really the referral may be for evaluation. It may be for testing decisions about specialized x-rays, regular x-rays. It may be for interpretation and treatment and follow-up and what are your subspecialty alternatives and all that. So let's just highlight a couple things and we'll go over this in the practical. But you can clearly treat sprains in the office, and volar plate injuries are unbelievably common. So somebody gets hit with a basketball, they get hit with a volleyball, they bend their finger back, they're going to have ecchymosis and swelling in the front of the joint, and it's going to be tender there. And that's a ubiquitous injury that's going to be stiff. And probably the biggest trouble with volar plate injuries is overtreatment with splints that lead to tightness. So we're going to talk today about how do you put on buddy taping, how do you do koban, when do you move them, how do you get them moving, et cetera. Overuse injuries, you know, it's really trying to be certain you have the diagnosis correct. When do you arrest them and restrict them? Who gets regular x-rays, but most importantly, special x-rays like Carly talked about, MRIs and ultrasounds. And then we'll go through splinting and therapy referrals and return to sports. And the problem with the bottom is if you don't do that a lot, it's hard to sort out, can this kid go back and play? Can they not go back and play? You know, dad and the coach want them back on the field today. Is that reasonable or unreasonable? How do you sort through that? And that's a little bit of a bigger question that we may have to tease out. You know, buddy taping is like ubiquitous. We use it all the time. The only way you get in trouble with buddy taping is if you block the joint, so you put it on too tight. So you don't want to be constricted so you affect the blood supply. You put it in between the joints so they can move. And really the goal is to prevent contracture while they heal, and then subsequently to return to sports without repeat injury. Ligamentous laxity is really important to sort out in the office on exam, and Don touched on this, but you gotta test for these kids. They'll oftentimes complain about pain and numbness and tingling in their wrist, and you might think it's carpal tunnel. Carpal tunnel in kids is really uncommon, but laxity that gives that sort of pain is really common. So you can rest them and you can splint them and you can rehab them. And the rehab is really a lot of closed chain exercises. But if it gets unclear, then you got to sort out who gets an MR and et cetera. Probably 80% of what we see in the wrist pain is that. There are going to be these minor fractures, and which ones should you take care of? So we're going to focus a little bit on mallet fingers today for how to initially start to splint it or even necessarily treat it. But you get into this evaluation, temporize, and then triage. So mallet fingers are very common. The finger gets jammed. They have inability to extend, and we're going to point out how to properly splint them. Radiology referral, really have a low threshold for this. It helps discriminate treatment injuries. It really helps set treatment. And specific fractures that are really problematic if missed and come in late are these intra-articular fractures, phalangeal neck fractures, oblique or displaced fractures. So you got to be really careful about that. You know, who goes to the ED? Any open wound should go to the ED. That's pretty obvious. Really crooked bones should go to the ED. Unreduced dislocation should go to the ED. And those are almost going to be obvious from the panic of the mom calling you on the phone before you see them. This is a key thing that we talked about on tenodesis. What you're really looking for is the crooked finger. A two-dimensional x-ray won't show you a crooked finger, particularly if it's not a true AP and lateral of that injured finger. You just won't see it. And so being able to do a tenodesis exam and pick out the crooked finger really counts. We got to mention triggers. So you'll see a lot of triggers, trigger thumbs. And sometimes people will think he dislocated and I reduced it and I felt a pop. And that's the trigger nodule going back and forth. So if somebody tells you they got a 2-year-old with a dislocation, 9 times out of 10 it's a trigger thumb and it's not a dislocation. But the radiologist may call it a dislocation on the x-ray. Trigger fingers are a lot less common. These Seymour fractures may look like mallet fingers, but what you'll see is that the nail plate is out of place. And so when you see something that distorted, that either needs to go to the ED or to the OR to have treatment. Dislocations require reductions. Most of the time these happen on the field. And so then afterwards, what do you do about them? And you can temporize them with splinting, koban, buddy taping, and you may even be able to treat them, although most of the time it's managed by us because we're trying to sort out, are they reduced properly? And what we're really looking for is crooked things that don't stay crooked forever, because like this finger on the left there, the parents weren't very happy that it ended up that way in the long term. So this subtle tenodesis helps you a lot. And we want to be certain that the dislocations actually truly reduce, and that's where an x-ray really helps us out. We're going to touch on this TFCC, but you ought to just know that term, but ulnar-sided wrist pain is pretty common, and so we'll go over that on the exam. I just want to mention jersey fingers, because sometimes you don't see this, but if you open up your fingers wide, you'll see the long finger longer than the ring finger. If you close your fist, your ring finger is longer. So when a soccer player or football player grabs a jersey, they can pop their flexor tendon if that player takes off. And the only way you're going to know this is on specific exam for the profundus tendon. So keep that in mind, and we'll touch on that for it. Remember infections, so these canaval signs sometimes are infectious, but that's going to be a fat, swollen, painful finger. And gamekeepers' thumbs in kids are really displaced injuries, so we're getting towards ski season, and you just got to think about these. But these are then all kind of higher level things. So today we'll touch on splints. We have no commercial interest, but there's lots of different types, so we're going to go over which ones and how to use them. No conflict of interest. We're going to talk about mallet fingers in terms of how you splint them and what you do. And we tend to use this dorsal splint because it can allows for motion. We're going to talk about koban, and just remember koban's, it's great. It's like an ace bandage for fingers, but you can get into vascular compromise. So you need to educate people how to do this if you use it. And then we're going to talk about standard wrist splints and some spica splints.